Hello, my name is Brian Ramacco, and today I'd like to talk about corticosteroids. Corticosteroids are greatly overused in today's medical practices. If someone goes in knee pain, shoulder pain, hip pain, the first thing the doctor does is they get the needle ready and they inject them, and they're, oh, what was that? Oh, yeah, this is just a steroid injection. It's for the pain. But was that the right thing to do? And was the patient making an educated decision in that process? Now, just to give you an example, before I go into my explanations here, is I was talking to a medical doctor. I was helping him with hip pain, and he was telling me he needed to go to another doctor to get an MRI for his hip, and that other doctor, had the needle ready to go and says, "Oh yeah, just pull down the pants a little bit. I'm just going to inject you with this." He's like, "Whoa, whoa, whoa, whoa! What the heck are you doing?" "Well, I'm just going to inject you with some steroids. I do it to everybody." He's like, "What are you doing?" He ended up being an expert in inflammatory conditions. So he knows, like he had blood work done, he knows he has nothing inflammatory wrong with his body. He's like, "What are you doing? There's nothing inflammatory there. Why are you injecting me with an extremely strong anti-inflammatory with strong negative effects?" It but not everyone has the confidence to tell the doctor no. um, and doctors don't take the time to explain benefits versus the negatives of a steroid injection. And they don't, they sometimes don't give you the time. And sometimes the diagnosis they're working on is wrong, which is the other problem. If the diagnosis the doctor is working with is wrong, then he might be thinking he's doing the right thing, the obvious thing, but he might be doing the wrong thing. Not all doctors are up to date with the latest research. Not all doctors are going to do an in-office musculoskeletal ultrasound to see if what condition you have, to see if an injection is the right treatment. In general, though, steroids are a symptom-based treatment and not curative. There are a few conditions that it is curative, so I'm not against steroids entirely. I'm against the incorrect use of steroids, and I'm against using them without the patient making an educated decision. Steroids do provide some short-term pain relief, and my goodness, if I was in so much pain I couldn't move, or I had a patient in so much pain they couldn't move, well, that's no good. You have to move to live. Um, so in those cases, it can make sense. But if it's like, oh yeah, it hurts a little bit, the patient should be given a choice. Well, do you want some symptom relief with some possible negative side effects, or can you live with it? But often they aren't given that choice. So anyway, that's why I'm going to rant today about steroid injections. So first off, what do steroids do? What does a cortisone injection do? And there's other corticosteroid injections. So they inhibit the immune system. And the immune system is what causes inflammation in your body. Your immune system is attacking something, breaking something down. When you're injured, it has to break down all the injured tissue so that the new tissue can take its place eventually. So if you have a very strong inflammatory response, there's a lot of swelling, a lot of redness. If you take a steroid, then that will basically turn that off. Great. But we need an inflammatory response it's part of the healing process. Also, by turning off the inflammatory response, it has other negative effects to the nearby cells. In particular, it seems to inhibit the production of collagen and healthy collagen. And collagen is necessary to make up your skin, your bones, ligaments, tendons, and often these are injected for tendon issues and ligament issues. So and even cartilage, it can have a negative effect on cartilage, and there's some debate about whether it can cause or speed up osteoarthritis. So it's definitely a very strong anti-inflammatory, except it inhibits collagen production and proper collagen production. It seems like it does provide some pain relief, although there are some studies that found that it doesn't provide pain relief compared to placebo. So it might be more of a placebo effect. Now I've seen different results depend on what part of the body. For the back, it doesn't seem to make a difference. For chronic back pain, it seems to be a placebo effect. Other parts of the body, it does seem to have an effect when compared with placebo. So mileage will vary for the pain relieving effect, but you have to accept that the negative consequences of that. One of those negative consequences I mentioned, weakened collagen, you can end up with more pain later. And in particular, you can end up with tendon ruptures. I had one patient I tried to help, but she was just so scared of exercise that in the end, she's like, no, I can't do it. I'm not going to do exercises. She just had basically sworn off exercises ever again, where, as you know, with chronic problems, you have to rehab to get fully better. But what happened is she got a whole bunch of cortisone injections, and then specifically cortisone injections right into her Achilles tendons for Achilles tendinitis. And then the physiotherapist did the correct exercises for an Achilles tendinopathy, and both of her Achilles tendons ruptured, just snapped. So obviously she's scared of that happening again and doesn't want to do any more exercises. But the cortisone greatly increases the risk of your tendons snapping. So it's not considered good. If you read recent systematic reviews, meta-analysis, I read another one very recently because there were a few studies that seemed to suggest a positive result with cortisone. And so the authors thought it was another good time to update with another systematic review, meta-analysis. And they said, no, still looking at these studies, looking at the bias in these studies, it's still the case that for tendinopathies, cortisone is not recommended. In fact, they were a little tongue-in-cheek about it. They said hasta la vista, because this procedure, cortisone injection, should be terminated. It should be done. It is a closed book. The risk versus the reward, it is not worth it. As I mentioned, there might be cases where it is worth it, in which case they should go in with ultrasound guidance. Don't put directly into a tendon, put on the surface just a little bit, as little as possible to get that pain relieving effect. Okay, there's my rant there. I haven't mentioned about the misdiagnosis part though. So tendinitis, bursitis, epicondylitis. If you're watching this and you've had chronic pain, talk to a doctor. I'm sure you've been diagnosed with one of these things before. They're lies. Probable lies. Now you can get bursitises and tendinitises with an autoimmune condition or with an infection. But a chronic tendinitis, a chronic bursitis, a chronic epicondylitis, those diagnoses we now know are wrong. They were taught in medical school. And I was even taught them in my medical schooling as well, or my chiropractic schooling as well. And then I went and did specialty training, my neuromusculoskeletal medicine specialty training, and my musculoskeletal sonographer training. And in both those specialties, they're like, oh yeah, with the recent research, no, those diagnoses are wrong. The process is degenerative rather than inflammatory. While there are some increases in the inflammatory markers, it's not an inflammatory process. It's mucoid degeneration. So it's degenerative. It's weakening rather than an inflammatory process. So an anti-inflammatory is the wrong treatment in those cases. So doctors have been told, bursitis, epicondylitis, tendinitis. The itis suffix means inflammatory, inflammation. So they think, okay, epicondylitis, I use a strong anti-inflammatory. That's the treatment. They link the term with the treatment. But we need to start renaming these conditions so doctors don't automatically think inflammatory, because it's not inflammatory. So instead of a tendinitis, other specialty practitioners like myself, medical doctors and people high up in the field, they're trying to change the wording that we should stop calling these tendinitises. They're a tendinosis, which means degenerative instead of inflammatory. Instead of a bursitis, it's bursal distension. The bursa has fluid in it, and it's filled with things, but in the research, well, in some parts of the body, there's still a debate about whether it's painful or not. But in particular for the hip, where a lot of people are diagnosed with a trochanteric bursitis, the bursa isn't causing any pain. You can cut the person open, take the bursa, throw it away. The person's still in pain. It turns out that the bursa tends to fill with fluid when a tendon nearby is torn or weakened and sickly. So, so it's not a bursitis, it's bursal distension. It's not this inflammatory process. The bursa fills with fluid to help cushion. A bursa is is a cushion in your body, and it fills with fluid when your body thinks it needs more cushioning, when one of the tendons is angry and painful. And of course, with a lot of these tendinopathies, the muscles are also painful, but a lot of doctors don't go into, of course, checking if your muscles are painful and muscle testing, what tendons, what muscles. Very few people spend the time on people in chronic pain to really delve into what structures are causing the pain. As an imaging specialist, as I like to say, I'm very interested in chronic pain, getting down to the bottom of things. The current medical system just doesn't give you the time to really delve into things. And I had to go basically behind my boss's back often to spend extra time with patients to try to figure things out. So, so one problem is the medical problem. Medical education, particularly that these problems are tendinosis or tendon tears and not a tendinitis. And itis, since it's not an itis, then a strong anti-inflammatory isn't necessary. Well, again, if it's hot, inflamed, maybe it is, if there is an inflammation, but often most of these cases, it's not inflammatory. Again, I'm not against cortisone when it's used, when it should be used. I'm against using it blindly for pain in a region, because it can lead to negative side effects later. I'll mention one point where cortisone is recommended is trigger finger. It's when a tendon, and the tendon has to go through a pulley, and basically the tendon becomes inflamed and too bulky. It doesn't fit underneath the pulley anymore, and the pulley can become thickened. Well, so cortisone weakens collagen, and in fact, it breaks it down. So if you have too much collagen, a thickened tendon that doesn't slip under, it turns out that with trigger finger, with an injection or two, it's curative in most cases. And of course, if it doesn't work, then you can go the surgery route. And you can try conservative therapies before going to the cortisone injection, of course. I just wanted to mention that cortisone does have some appropriate use. And I mentioned really hot, swollen, inflamed, throbbing joint. Yeah, it can be a good decision. And if someone's in so much pain they can't move, a little bit just to knock down a little bit of pain so that someone can move, then they don't have to do so much rehab later if you can keep someone moving. So I'm not against cortisone 100% of the time, just when it's used inappropriately, which is blindly for any type of pain, joint pain, or tendon pain, where it's likely tendinosis and not tendinitis. It's unlikely a bursitis, it's more likely bursal distension. Same thing with an epicondylitis. This is most likely a tendinosis or muscle knots in the forearm. So I hope you found this informative. I hope it leads to less steroid use out there in general. Talk to your doctor. Don't let your doctor inject you blindly with cortisone. Talk about the pros, cons. Get into a discussion as to how accurate is this diagnosis, is it inflammatory. You have a right to a discussion. You have a right to know what's going on. You have a right to help manage your body. No one is more an expert in you than yourself. You need to be a participant in managing your health. You're a specialist in you. Doctors are specialists at whatever they do, whatever type of doctor they are, and it's collaboration. So I wish you the best. Good luck. Cheers.